I'm about to pass it over to my colleague Ponsiano, who, as Dr. Kirk mentioned, is an associate professor at Makerere University and is involved in a number of studies, as was touched upon. And he's also president of the Uganda Gastroenterology Society. I really appreciate him coming on and give some additional perspectives from his studies and practice in Uganda. Ponsiano?
Thank you very much, organizers. Thank you, Greg, and all the presenters. Greg has actually talked about most of the things that we are doing in Uganda, but I will take it on from there. First of all, the hepatitis B is the major cause of liver cancer here in Uganda, both in HIV and non-HIV infected patients. And as was mentioned, it presents very late, and most of our patients are dying very quickly, and they are living only for about 1.5 months from the time of diagnosis. And so they are really presenting with stage D disease. Of course, government has had a number of programs to try to reduce the incidence of hepatitis B in this country. For example, we are testing for hepatitis B, HIV, HCV, and syphilis in the blood transfusion service, and consequently leading to reduced transmission through those processes. Also, in the year 2002, government introduced the pentavalent vaccination for the babies given at 6, 10, and 14 weeks post-delivery. And it has been relatively successful, actually, largely. And also introduction of auto-destructive needles so that you don't have to continue using these needles. And earlier on in the year 2004, we had a national series survey that showed Uganda had about 10% of the population nationally with chronic hepatitis B, most of it being the northern part of Uganda. And as you go south, the burden goes lower. In the north, we had about 20 to 25% of the population having hepatitis B. In the south, and especially in the southwestern part of the country, this was about 4%. And in the year 2015, government launched massive testing of hepatitis B in the whole country, actually. And that was about 6 years ago when we started. And we planned to screen 17 million adolescents and adults in the country at that time. By the end of the 5 years, we were able to screen at least 5 million, and we identified about 370,000 with hepatitis B infection. But there were some challenges with this. First of all, the intention of the vaccination was to vaccinate all those who were surface antigen negative, and link all the surface antigen positive persons to care. Yes, most of those who actually tested negative got the first dose of the vaccine, but by the time they were getting the third dose, they were only about 18% of those who actually got the first dose, got the third dose, because of the difficulties in trying to get these persons back to care, to get the vaccination. And eventually, the program was not very successful in terms of the vaccination, but those who were identified as positive were actually linked to care. Government opened up hepatitis B clinics in all the regional hospitals to take care of these persons. But these clinics were really not well served at all compared to what we were seeing in the HIV clinics, which have got a lot of funding. I mean, quite a bit of funding from donors and the rest. And that was the reason why we went on to try to test the integration of the hepatitis B mono-infected patients into the HIV setting, which we did in 2 sites in the most prevalent areas. And this was in form of, we did this in form of implementation of science research, and it was quite successful. 2 years ago, this program ended what we were doing, but to date, all the patients going to those hospitals are actually being taken care of in the HIV clinics. And we were very happy. We're now trying to see how we can roll this out to the other parts of the and the other hospitals in the country. Now, in 2016, there was another sero survey. Remember, the pentavalent vaccine was introduced in 2002. The first sero survey was in 2004. In 2016, we had another sero survey, which now shows the national prevalence of hepatitis B dropping to 4%. And this is really quite appreciative. But the report from the Ministry of Health is still showing about 3,000 children getting infected every year with hepatitis B. Now, that talks a lot about the vaccination program and how it is going using the pentavalent vaccine and the lack of the birth dose. And that has led us to set up this other program, which Greg talked about, to do the PMTCT, HBV PMTCT study. Actually, I spent the whole of today doing protocol training for that study. And we plan to screen 37,000 pregnant women and then identify those who are positive and divide them into 2, those who have high viral load. And here we are using 20,000 as a cutoff. Those who are more than 20,000, we are giving them tenofovir, and those who are less than 20,000, we observe them, but at birth, all the babies get a birth dose, and then we follow them and see at 9 months post-delivery to see what is going to happen in terms of the infection in the babies that have undergone this. Of course, the babies will have to go on with the pentavalent vaccine as well to complete, so they will receive like 4 doses. We are hoping that this will have some impact. Recently, the NITAG, the National Immunization Technical Advisory Group, approved birth dose, but government doesn't have the money to really procure this birth dose. Fortunately for this study, they used the hepatitis program money to procure for us the birth dose. But we are going to certainly have some challenges to really introduce the birth dose nationally. And we hope that this, the finding in this study will help actually to convince them to continue with this. I think that's what I can say. And we are hoping that the burden of liver cancer will begin to drop down with time, because we still have a huge population with chronic hepatitis B, especially those adults who, in most cases, got this infection in early childhood. Thank you very much.